to the dosage of fosamax, because it's usually increased than the other. It takes a longer period for the bisphosphonates to install, so it's going to be approximately 2 years. Think about having 24 doses, is 1 dose monthly, so it's 2 years with bisphosphonates to impregnate the whole bone and the patient to be at risk. It is installed faster if the bisphosphonate is associated with corticosteroids or methotrexate. And as I said earlier, the exposed bone is going to be smaller, and we won't have any third stage classification in the orally administered biphosphonates. So, if the patient, we're talking about the oral administered ones, if the patient is in treatment with biphosphonates for a shorter than 2-year period, he's at the minimum risk. 2 to 3 years, he's in a medium risk, and over 3 years, the risk is increased. We also need to assess, it's very important, the CTX. It's the C-terminal crosslink. It quantifies the bone turnover. It's correlated with the systemic suppression of the bone recovery. You can only use it in case of oral bisphosphonates, and of course not in the patients with malignant diseases. When the CTX is over 150, you are safe to proceed and do any therapeutic surgery on the patient. When we do the IV administration, it's really important for the oncologist to send the patient to a dental office, or maybe to the oral maxillofacial surgeon, because 75% of the osteonecrosis happen by occlusal trauma, surgical trauma, and bone inflammation. So first of all, you have to report on the importance of health. And we need to avoid the need of dental alveolar surgeries after initiating the biphosphonate, so we have to do everything before. That's why it's really important to have a good collaboration with other specialties, such as oncological in this case. The oncologist, as I said, needs to guide the patient into the dental office. If you can, you should postpone the initiation of therapy for 2 to 3 months, so you can act and do every dental surgery you need, and have the 2 or 3 months after in order for the bone and the soft tissues to heal. Of course, if the delay is not possible, you can start the rehabilitation as quick as you can, because as we know from before, it takes up to 3 doses for the risk pumping, so we are safe for the first 3 months. In any patients that do not require surgery, of course, the therapy should not be delayed. So if the patient does need dental therapy, but it does not involve any type of bone surgery, we can proceed with the administration of the biphosphonate and work in parallel with any, let's say, endodontic treatment, cavities, and anything else. What's important to do? Scaling, extraction of irrecoverable teeth, and bear in mind here that we should think about the tooth if it's going to be viable in the next 5 years. Don't think on the short term. Treatment of the periodontal disease, any endodontic surgery therapy, like apical apicectomy, let's say, any restoration of dental lesions, elimination of occlusal trauma, bone prosthetic surgery, and in the case of intravenous administration, the dental implants are not indicated. Now, if the patient already started the bisphosphonates treatment when he comes to your office, you should carefully examine the oral cavity to detect possible lesions. Of course, use the imaging like CBCT, CT, anything. You should look for inflammatory lesions in the maxillary bone for osteolysis, And your main goal is to maintain an optimal oral health to prevent the osteonecrosis. In oral administration, of course, it's the same, but it's easier because the patient has time for oral rehabilitation for up to 2 years. So implant therapy is possible. You have enough time, but take in mind that if a patient tells you that he takes, let's say, oral bisphosphonates for a year, let's say Fosamax, check his medical history, see if he didn't take anything else before, a different type of bisphosphonate, and he didn't know about it. So be really careful. If the patient, let's say, has 3 years of oral bisphosphonates, what you can do is for him to take a drug holiday. So 9 months prior to any therapeutical surgery and 3 months after for healing. So if a patient took more than 2 years of biphosphonates, he can do a drug holiday, and after 9 months, you can do any therapeutical acts. These are some cases of intravenous administration of biphosphonates. When a patient comes in your office like this, you should inform about the condition. You should try and do a multidisciplinary collaboration with your colleagues and treat him depending on the clinical stage. The bone exposure is going to be permanent in the intravenously administered biphosphonates. You can see here, this is an image with the teeth present after the extraction. You still have the necrotic bone and the mucosa that's suffering overlying it. The bone is not problematic in the in this necrosis because it doesn't hurt; it's denervated. The patient will feel pain and will suffer when it becomes infected. So your goal is to keep that bone not to get infected. There's some antibiotic treatments. There are three types that you can go with. The first one is with penicillin for a long time, because you can give it for years and it won't be a problem for the patient. If the patient has penicillin allergies, you should replace it with amoxicillin with clavulanic acid, cephalosporins. You have here different doses, but maximum of 10 days because of the risk of tendon rupture, liver toxicity, and kidney toxicity. So only the penicillin can be taken for many days. Metronidazole should also be given for the patient, but only a maximum of 10 days. And do not give clindamycin alone, because it's not effective on 3 of the species involved in the bone infection. This is a third stage case of osteonecrosis. It goes here right at the level of the basilar mandible. In this case, with Dr. Otaro did a resection. So half of the mandible was resected. We're trying to go in the healthy bone. This is the resection piece, and it was replaced with a titanium bar. This is the patient after a couple of months healing. About the intravenously administered, it's really important. If you interrupt it, it should only be interrupted by an oncologist. The necrotic bone will not sequester after the biphosphonate discontinuation, as it happens in the oral administered one. The lifespan of the biphosphonate on the skeleton is more than 11 years. and the bisphosphonates, the intravenously administered one, should only be discontinued if it's no longer necessary for metastasis control. In the oral administration, of course, as I said, is less extensive. We won't have the third stage. It responds well to stopping, so it responds well to drug holiday. We should talk with the endocrinological specialty and interrupt it for 1 year. So 9 months before therapeutic intervention, 3 months after. It should be administered to the patient discontinuously, so 2 years with 1 year of drug holiday, and this should continue all along. This is a patient that took oral biphosphonates. As you can see here, there's a necrotic bone, and it is exposed. After stopping the biphosphonates, it just fell apart, the part of bone that was necrotic. We took it out, and then it just started healing by itself after a couple of months that the patient didn't took any oral biphosphonates. And as you can see here, this is a healing of a couple of weeks. We could, after the drug holiday of 9 months, we could take out the rest of the teeth, and it healed properly. There are other drugs with similar effects as the biphosphonates. As I told you in the beginning of the presentation, the most known are the denosumab, which is the RAMP inhibitor, the bevacizumab, which is an anti-angiogenic drug that inhibits the vascular endothelial growth factor, and sunitinib, which is the RK inhibitor. There's some information about every type of antiresorptive medication, how does it act.